Welcome back. In the chapter of health programs in India, in today's session we will deal about Janani Suraksha Yojana, the National Maternity Benefit Scheme. The National Maternity Benefit Scheme now has been modified into a new scheme called as the Janani Suraksha Yojana. It was launched on 12th April 2005. So we see the Janani Suraksha Yojana was launched on 12th April 2005. The target group under this scheme are all the women belonging to the BPL below poverty line households, the women belonging to below poverty line households who are 19 years and above of the age 19 years and above and up to two births, the women up to two births and who are aged 19 years and above and falling under the below poverty line households are the target group. The objective of this scheme is to reduce the maternal and neonatal mortality, Janani Suraksha. So we are preventing or reducing the maternal mortality, the maternal deaths, and infant mortality, the neonate or an infant's mortality. To promote institutional delivery among the poor pregnant mother, we are also promoting institutional delivery. So instead of the home deliveries, we are promoting the institutional deliveries in the poor pregnant mother. Okay, promotion of institutional deliveries. Clear the objectives: reduce maternal and neonatal mortality, promote institutional delivery. Moving forward to the salient features of the Janani Suraksha Yojana. The salient features are: it is a 100% centrally sponsored scheme. So it is sponsored centrally. The central government of India is sponsoring the Janani Suraksha Yojana scheme. And under the National Rural Health Mission, it integrates the benefit of cash assistance with institutional care. So we are providing the cash assistance to the institutional care during antenatal, delivery, and immediate postpartum care. We are providing the benefit of cash assistance to the women who are undergoing the antenatal, delivery, and immediate postpartum care in the institution. This benefit will be given to all the women who are belonging to both urban and rural areas and who are belonging to the below poverty line households, and all those who are aged 19 years and above up to first to live birth. So we have studied about this. So the benefit will be given to the target group, that is the women, all the women both in the rural and urban areas who are belonging to the below poverty line, aged 19 years and above and first to live births. The accredited social health activist, which is nothing but the ASHA worker, would work as a link health worker between the poor pregnant women and the public sector health institution. So the ASHA worker will act as a link health worker. She is acting as a link health worker. So the poor pregnant mother. So she is a poor pregnant mother, and the public sector health institution. The public sector health institution, who is acting as a link worker, who is connecting this poor pregnant mother to the hospital, public sector health institution. It is the ASHA worker who will act as a link health worker to connect the poor pregnant mother to the public sector health institution. What are the scales of assistance under the Janani Suraksha Yojana? In the rural areas, we have this table, okay. Under the scheme of 2012 to 2013, we have the scale of assistance, which is divided in the rural areas as well as the urban areas. The low performing states is the LPS, and we have categorized the states into low performing states and high performing states in the rural areas and in the urban areas. We are providing the mothers package, Asha package, and the total rupees. Mothers package, Asha package, and calculating the total. In the low performing states, we are providing 1400 mother packages and Asha package is 600. Thus, the total rupees is 2000. So we see the incentives what we are giving to the mothers in the low performing states. Rupees 1400 is given to the mother. In the high performing states, 700. The Asha's package, that is the Asha who is accompanying the pregnant mother for the institutional delivery, she will be given 600 in the low performing states and 600 also in the high performing states. So the total amount you have to calculate. Next, in the urban areas, the mother's package, the mother is receiving 1000 rupees and Asha is receiving 400 rupees. And in the high performing states, 600 for mother and 400 for Asha. Okay, so the Asha package 600, 400. In rural areas, it is 600 and in urban areas, it is 400. Now comes the low performing state, high performing state. 1400, 1000. 700, 600. Clear, guys? So the low performing state is nothing but LPS, high performing state is HPS. Asha incentives of rupees 600 in the rural areas. It will include rupees 300 for ANC component and 300 for accompanying the pregnant mother for institutional delivery. This 600, 300 for accompanying the mother. The other 300 incentives is for the antenatal care component. Asha incentives of rupees 400 in the urban areas. It will include 200 for ANC component, antenatal care component, and other 200 for accompanying the pregnant mother for the institutional delivery. Clear, guys? So this is the scale of assistance. I hope it is clear. Let us just revise it. The scale of assistance, we see urban area, rural area. We have mother's package, Asha package. Mother will get 1400 in low performing state and she'll get 700 in high performing states. Asha worker will get 600 in both the states. Coming to urban areas, the low performing states, they will receive 1000 rupees. There 1400, here 1000, and 700 in rural urban areas they get 600, the mothers, as an incentive for performing the institutional delivery. And the other incentives provided for the Asha is 400 again in low as well as high performing states. Moving further to the eligibility and limitation of this cash assistance. In the low performing states, all the women, including those from the SC, ST and families, they are delivering in the government health centers like sub-centers, primary health centers, community health centers, first referral unit, general wards of district and state hospitals or accredited private institutions. The limitation of cash assistance is because to all the births. Okay, in low performing states, all the births are delivered in the health centers. So there is a limitation of the cash assistance. Whereas the high performing states below poverty line, the women are aged 19 years and above, and SC, ST and pregnant women are the one who are getting this cash assistance, and they are given up to 2 live births only. Okay, clear, guys? In the low performing states, SC, ST women are delivering, including all the women along with the SC, ST, all women are delivering in the government health setup. In high performing states, only BPL women aged 19 years and above and the SC, ST are pregnant women are delivering in the public health institution. Limitation of cash assistance, here it is given to all births, it is up to the 2 live births. Vande Mataram scheme. Now we move forward to the Vande Mataram scheme. This is a voluntary scheme wherein any obstetric and gynac specialist, the maternity home, nursing home, lady doctor or MBBS doctor, they will volunteer themselves for providing safe motherhood services. So we have varieties of volunteers, that is obs and gynac specialist. Then comes the doctor, MBBS doctor. First the specialist, you can remember like this, obs and gynac specialist, MBBS doctor, maternity home, nursing home. maternity home, and nursing home. They will volunteer themselves for providing safe motherhood services under Vande Mataram. Okay, Mata. You can remember like this, Mataram. So, Mata, we are providing safe motherhood services. The enrolled doctors will display Vande Mataram logo at their clinics, and these doctors who are enrolled under the scheme will display the Vande Mataram logo at their clinics. Iron and folic acid tablets, oral contraceptive pills, tetanus toxoid, TT injections, etc. will be provided for free distribution under this scheme. Under the Vande Mataram scheme, along with the safe motherhood services, we are providing iron and folic acid supplementation, OCPs, TT injection, immunization will be carried out. They will be provided for free distribution. Moving forward to the safe abortion services. Under the safe abortion services, we have the RCH phase 2. The following services will be provided. We know that RCH phase 2 has the medical method of abortion, wherein the termination of the pregnancies will be done with the help of the two drugs, that is mifepristone followed by misoprostol. So we see the medical method of abortion. Medical Termination of Pregnancy Act of 1971, wherein we will administer two drugs, that is mifepristone and misoprostol. It is recommended up to 7 weeks pregnant, 49 days of amenorrhea. Okay, for the 7 weeks pregnant, 7 weeks. Okay, don't forget this method is recommended only up to 7 weeks of pregnancy. Next, we have manual vacuum aspiration. The manual vacuum aspiration has been piloted in coordination with FOXY, that is Federation of Obstetric and Gynecological Societies of India, World Health Organization, and respective state governments. So this manual vacuum aspiration, this has been in coordination with Federation of Obstetrics and Gynecology, Federation of Obstetrics and Gynecology Societies of India, Gynecological Societies of India. We have Federation of Obstetrics and Gynecology, Gynecological Societies of India, World Health Organization, and the state governments in coordination with RCH Phase 2, who are providing the manual vacuum aspiration. Village Health and Nutrition Day. So, under the Village Health and Nutrition Day, they are organizing Village Health and Nutrition Day once a month at each Anganwadi centers to provide the antenatal postpartum care for the pregnant mother. So, the Village Health and Nutrition Day is carried out once a month. Okay, it is carried out once a month in Anganwadi centers to provide antenatal postnatal care to the pregnant women, promote institutional deliveries, provide accurate health in education, immunization, family planning, and nutrition services. So, what are all the things we provide under the Village Health and Nutrition Day? The promotion of institutional delivery. Okay, promotion of institutional delivery. Then we have immunization. Then health education regarding the family planning and nutrition services. You can say health education, family planning, and we have nutrition services. Maternal death review. The maternal death review as a strategy has been clearly spelled out in RCH phase 2. The maternal death audit, both facility and community based, it is a very important strategy to we are improving the quality of obstetric care and reducing the maternal mortality and morbidity. So we see maternal death review. It is both facility and community. Maternal death review is done both at the facility and communities. Maternal death reviews will be taken so that we can improve the quality of obs care and reduce the maternal deaths and diseases. What is the main objective or aim of the maternal death review? To improve the quality of obstetric care and reduce maternal morbidity and mortality. followed by the pregnancy tracking. The RCH phase 2 stresses the need for universal screening of pregnant women. Under the pregnancy tracking, we are stressing the need of universal screening of pregnant women and providing the essential and emergency obstetric care. Along with it, the focused antenatal care, birth preparedness, and complication readiness. We are having the birth preparedness and complication readiness. If such a any complication arises, we should be all prepared and ready. Skilled attendance at birth. The health worker who is performing the delivery has to be skilled within the first 7 days, etc. Care within the first 7 days, etc., are the factors which will reduce the maternal mortality. What are the things which will reduce the maternal mortality? If the antenatal care is focused, we are preparing for the birth, and if a complication arises, we are all ready with it. And skilled attendance at birth and care within the first 7 days, etc., are the factors which will reduce the maternal mortality. Moving further to the Janani Shishu Suraksha Karyakram. It was launched on 1st June 2011. Janani Shishu. Now in the previous program we saw Janani Suraksha Yojana. It was just Janani Suraksha Yojana. Here it is Janani Shishu Suraksha Karyakram. To make available better health facilities for the mother, Janani is the women, and Janani Shishu is the child. Okay, providing the better health facilities for the women and the child. The facilities which are provided to the pregnant women is: all the pregnant women who are delivering in the public health institutions will have free and no expense, including the C-section will be done free of cost with no expense at all. Under the Janani Shishu Suraksha Karyakram, we are providing a free institutional delivery, including the C-section to the women. The entitlements will include free drug and consumables. We are providing free drugs, free diet up to the 3 days during normal delivery, up to 7 days for C-section. First thing, we are providing free drugs. After drugs, the food, diet, drugs, the diet free of cost is provided up to 3 days in the normal delivery, up to 7 days for C-section. Free diagnostic and free blood tests. We are also facilitating free diagnostic and free blood transfusion when required. Free transport from home to institution and between facilities in cases of referral. If a complication arises and they had to refer the case to the higher level, we are providing the free transport from home to the institutions and also between the facilities in cases of referral. Similar entitlements for all the sick newborn. So we have the similar entitlements for all the sick newborn, providing the special newborn care under the Janani Shishu Suraksha Karyakram. The scheme has now been extended to cover the complications during antenatal care, postnatal care, and sick newborn. We are also covering the complications which are arising post neonatal care and the sick newborn and during the antenatal care. Moving further to the child health components. Under the child health components, the strategy for the child health care will aim to reduce the under 5 child mortality. What is the main aim? Aim is to reduce the under 5 year child mortality through the improved child care practices and child nutrition. By improving the child care practices and improving the child's nutrition, we can reduce the child mortality. The nutritional rehabilitation centers. So we see that we are improving the child care practices in child nutrition with the establishment of nutritional rehab centers. Severe acute malnutrition, Children under 5 years of age are taken care under this. The medical and nutritional care is provided. Medicinal care, along with the medicines, the nutritional care is provided to the severe acute malnourished children under 5 years of age. The services provided are as follows: 24 hours care and monitoring of the child. Under the nutritional rehab, we are providing the medicines and nutrition, 24 hours monitoring of the children, treatment of medical complications if there is, and therapeutic feeding, sensory stimulation, and emotional care. Also providing the emotional care and love to the child so that he can be cured of the malnutrition, severe acute malnutrition. So the risk factor has to be taken out if the emotional care has to be provided. Counseling on appropriate feed care as well as hygiene. We need to counsel the parents about the appropriate feeding, care, and hygiene. Demonstration and practice by doing of energy dense food. So we are also demonstrating the practice by doing the preparation of energy dense food by using those available locally available, culturally accepted, and affordable food items. With the use of these affordable food items which are locally available, we are demonstrating the preparation of energy dense food. Social assessment of the family. To identify and address the contributory factors, we should assess the social status of the family. Follow up of the children who are discharged from the facility. So these are the services which are provided under the nutritional rehab centers. The services are 24 hours care, treatment, of medical complications, therapeutic feeding, then sensory stimulation, emotional care, counseling, demonstration of energy dense food, and follow up of children who are discharged from the family. Integrated management of neonatal and childhood illness. Now we move further to the integrated management of neonate and childhood illness. IMNCI is one of the main intervention under the RCH phase 2. The objective is to implement the IMNCI package at the level of household and through auxiliary nurse midwives at the sub-center level, through medical officers, nurses, then we have LHVs and at the PHC level. So we see that at the various levels, at the PHC level, sub-center level, we are implementing the IMNCI package. So we have, let us see, at the level of household, objective is to implement the IMCI integrated management of neonatal care and childhood illnesses. Neonatal and childhood illnesses. The package has been launched at the level of households and through auxiliary nurse midwives at the level of sub centers and through medical officers, nurses, and LHVs. LHV stands for the lady health visitor at the PHC. Okay, at the PHC we have nurses, link health visitor, lady health visitor. Okay, we have link health workers, LHW, and we have LHN, LHVs, where link health visitor, V stands for visitor, at the PHC level. Clear, guys? Pre-service IMNCI. So IMNCI is being included in the curriculum of medical colleges. This will help in providing trained integrated management of neonatal and childhood illness manpower in public as well as private sector. Since the IMNCI is included in the curriculum of the medical colleges, they will help in providing the training of the IMN's manpower. They are providing the training to this manpower and providing the trained IMNCI manpower in public as well as private sector. Once the training is provided, these workers are working in the public and private sectors. Facility based newborn care. The health facility all the newborns at birth and sick newborn. What are the care they receive? At the PHC and subcenter level, as the maternal and child health level 1, at the first level, the newborn care corner is in the labor rooms. In cases of a sick newborn, the PHC will prompt referral of the sick newborn to the higher level. In the community health CHC, primary health center, and then we have PHC primary health center, CHC community health center, which acts as the first referral units, which is identifying as the maternal and child health level, second level. We are providing the NBCC in labor rooms and in operation theaters, and NBSU newborn stabilization unit in cases of sick newborn. In the district hospitals identified as maternal and child health level 3, the NBCC in the labor rooms and in operation theatre, the sick newborns have been undertaken by the specialized newborn care unit. Moving further to the home-based newborn care. The home-based newborn care is aimed at improving the newborn survival. Our main aim is to improve the newborn survival. The strategy is to universal access to the home-based newborn care. The strategy is implemented to achieve a universal access in the home-based newborn care. The providers of the service will include Anganwadi workers, auxiliary nurse midwives, ASHA and medical officers. Who are the providers of the service? They are Anganwadi workers, ANMs, ASHA, medical officers and so on. However, ASHA is the main person who is involved in the home-based newborn care. Who is the main person involved in the home-based newborn care? It is the ASHA worker. Moving further to the Navjat Shishu Suraksha Karyakram. It is a program aimed to train health personnel in basic newborn care and resuscitation. Navjat Shishu, newborn. Suraksha Karyakram, protection. So the newborn protection Karyakram is the program. So it is a program which is aimed to train the health personnel in the basic newborn care and resuscitation. It is launched to address the care at birth issues, that is prevention of hypothermia. The Navjat Shishu Suraksha Karyakram, Navjat Shishu Suraksha Karyakram, it is addressing the care at the birth issues. What are all the birth issues? It could be prevention of hypothermia, prevention of infections, early detection of breastfeeding and basic newborn resuscitation is the main goal. The aim is to prevent the hypothermia, birth issues, okay, in the kids, that is Navjat Shishu Suraksha, right? So we are protecting the baby, preventing the baby from infections, early initiation of breastfeeding and basic newborn resuscitation. Moving further to the Rashtriya Bal Swasthya Karyakram. It is launched in February 2013, under which there is a provision of the child health screening and early intervention services through early detection and management of 4Ds. So the early screening and intervention of the services is done through the early detection. Early screening is nothing but the early detection and management of the 4Ds. The 4Ds which are prevalent in the children. The first D stands for the defects at birth. The other D, deficiency conditions, diseases in children, developmental delays including the disability. So these are the 4Ds which are prevalent in children, and the provision of the child health screening and intervention services are done to prevent and manage the 4Ds. The 4Ds are defect, deficiency, disease, developmental delay. Defect, deficiency, disease, developmental delay. Okay. Thank you. With this, we come to an end of the various programs, that is Rashtriya Bal Swasthya Karyakram, Navjat Shishu Suraksha Karyakram, home-based newborn care, and then we had the child health components, Janani Shishu Suraksha Karyakram, followed by the Vande Mataram scheme and the silent features of Janani Suraksha Yojana. Thank you. With this, we come to an end of the session. If you like the video, hit the like button and subscribe. If you have any doubts, put in the comment section below.